in the next few minutes, you are probably going to stand up.
Most likely, yeah.
Right. And the exact moment you do that, gravity is going to just rip a full pint of blood right out of your brain and chest, and it's going to pull it straight down into your legs and abdomen.
It is a massive fluid shift.
Yeah. And if your body is even like a fraction of a second late in responding to that shift, you are going to hit the floor.
Ah.
Welcome to the deep dive. We take the sheer physics of walking around completely for granted, don't we?
Oh, absolutely. I mean, biologically speaking, every single time you rise from a chair, your body is essentially fighting off a miniature medical emergency.
A miniature emergency.
Mhm.
That is such a wild way to think about it.
But it's true. We are just walking around completely oblivious to this high-stakes physics problem that's, happening inside us dozens of times a day. Gravity is relentless. It pulls roughly the volume of, say, 2 standard water bottles out of your central circulation instantly. And when the internal system that fights that gravitational pull fails, well, it creates a major medical event, one that often goes completely unrecognized.
Which brings us perfectly to the mission for our deep dive today into the source material. We are looking at a condition called orthostatic hypotension, or OH.
Right. And the goal here is not just to learn some niche nursing vocabulary word, right?
Right.
We are going to deconstruct the actual mechanics of this invisible blood pressure drop.
Because it is a massive predictor of falls.
Exactly. We need to look at how it is consistently measured wrong in clinics and why this seemingly simple mechanical failure can actually serve as a crystal ball for your brain health years down the line.
I love that framing.
Yeah.
Because understanding this phenomenon, it really bridges basic physics with incredibly complex neurology.
Orthostatic hypotension. It sits at the exact intersection of everyday clinical practice and, well, serious life-altering consequences. Recognizing the mechanics of it can literally prevent a devastating, life-ending injury for someone you love.
Okay, so before we can understand why the blood pressure drops dangerously in some people, we really need to look under the hood at the incredible mechanics of a normal human just standing up.
The baseline, yeah. Let's walk through the physiology of it.
So, picture it. When you are lying flat in bed, your blood is distributed evenly, right? Returning venous blood flows horizontally back to your heart.
It doesn't have to work against gravity at all. The heart is operating with minimal resistance.
But the instant you stand up,
boom. 500 to 1,000 milliliters of blood is just pulled out of general circulation.
wow.
It pools in the veins of your legs, your pelvis, and your abdomen. Specifically, there's a region called the splenic venous bed.
Okay, let's define that splanchnic bed because the sources point out it's not just some random collection of veins.
No, not at all.
It is a massive, highly expandable venous reservoir that's designed primarily to aid in digestion.
Right.
Think of it like a giant, stretchy balloon in your abdomen. When you eat, it dilates to hold extra blood so you can absorb nutrients.
But when you stand up, gravity pulls your blood straight down into that highly distensible balloon. And if it doesn't immediately tighten up, the blood just stays trapped there.
And that trapping effect immediately reduces the volume of blood returning to your heart.
Exactly. Which means the heart simply has less blood to pump out with the very next beat.
So your cardiac output just plummets.
And that drop in cardiac output causes your blood pressure to crash. I mean, if nothing else happened in your body, your brain would be starved of oxygen within seconds, and you would lose consciousness.
You just pass out.
You'd pass out every time you stood up. You only stay awake because of this microscopic, lightning-fast, rapid response system.
Yeah, let's get into that. You have these pressure sensors, they're called baroreceptors, located right in the walls of the carotid sinus in your neck.
And in the aortic arch near your heart.
Right, and they are literally stretch receptors. When the blood pressure drops, the vessel walls become, less stretched.
They get a little slack.
Yeah, slack. And the receptors detect that slack immediately and fire an electrical signal straight up to your brainstem.
They send that SOS signal to a highly specialized cluster of neurons. It's called the nucleus tractus solitarius.
Okay, that's a mouthful.
It is, but you can basically think of this area as the brain's central circuit breaker for blood pressure. It constantly monitors that incoming pressure data, and it dictates the outbound response.
So the central circuit breaker gets the signal that pressure is dropping. It instantly triggers a surge of sympathetic nervous system activity by releasing a flood of norepinephrine.
Norepinephrine, which is essentially adrenaline's cousin.
Right. And its specific job in this scenario is to bind to receptors on your blood vessels and just aggressively squeeze the pipe shut.
It forcefully constricts blood vessels throughout your entire body, including that stretchy splanchnic balloon we talked about.
while simultaneously ramping up your heart rate.
Yes. This entire continuous loop, I mean, the sensors, the circuit breaker, the chemical clamp, it's called the Baroflex arc. In a perfectly healthy person, it fixes the pressure drop within about 30 seconds.
So fast.
Incredibly fast. Orthostatic hypotension only occurs when a link in that specific chain fails.
Okay, let's unpack this because the sources categorize those failures perfectly
Yeah.
using this plumbing versus wiring analogy, which I found super helpful.
It's the best way to visualize it.
Yeah. So first we have the plumbing, which covers the non-neurogenic causes. The sensory system and the brain's wiring are working perfectly.
Right, the brain is doing its job.
But there's a physical problem with the fluid or the pipes themselves. The tank is low or it's leaking.
Exactly. So a low tank is simple volume depletion. The patient is severely dehydrated or maybe bleeding, or they've been overprescribed diuretic medications that just flush way too much water out of their system.
They just literally don't have enough fluid to pump.
Right, but a leaky pipe scenario is slightly different.
That's where the pipes are too relaxed.
Yeah.
Usually because of medications.
That's exactly.
Like a lot of everyday blood pressure drugs, certain antidepressants, or even prostate medications, they act as chemical roadblocks. They literally block the norepinephrine from doing its job.
The brain is screaming to constrict the vessels, but the medications act like leaky valves. They prevent the pipes from tightening.
And prolonged bed rest causes another plumbing issue, doesn't it?
Oh, a huge one. If a patient is hospitalized and immobilized for weeks, that Baroreflex literally atrophies from disuse.
It just forgets how to work.
Well, the body is ruthlessly efficient. If you don't use that reflex to fight gravity on a daily basis, your body just starts expending the energy to maintain it.
Wow. Okay, so that covers the plumbing. But then we have the wiring, which covers the neurogenic causes.
Right.
In this scenario, the fluid tank is completely full. The patient is perfectly hydrated. There are no leaky valves at all.
But the sensors or the signaling wires themselves are completely degraded.
So the brain never gets the message that the blood pressure is dropped in the first place.
Or the brain's command to constrict just never reaches the blood vessels. We see this a lot in conditions like Parkinson's disease or diabetic autonomic neuropathy.
And you can actually tell which of these two problems a patient has right at the bedside, can't you? By looking at one simple physiological clue.
Yes, their heart rate. It's such a brilliant clinical distinction.
How does that work?
Well, if a patient stands up and their blood pressure crashes because of a plumbing issue, let's say severe dehydration, their nervous system panics, right? The wiring is totally intact.
So the brain detects the crisis.
Exactly. The brain screams at the heart to beat faster to compensate for the dangerously low fluid volume, so their heart rate will just shoot up dramatically.
But if it is a wiring problem, the heart rate barely rises at all.
Right, because the baroflex itself is broken.
So the blood pressure is plummeting, the brain is getting less oxygen, but the heart just keeps beating at this totally normal resting pace because the communication lines are completely dead.
It is a terrifyingly quiet response to a major physiological crisis.
Because the human body has so many different ways to fail at something as fundamental as standing up, the medical community spent like a century arguing over how to actually define and label the failure. Right?
Oh, absolutely. I mean, the condition was noticed for centuries, obviously. People fainting when they stood up wasn't exactly a secret.
Right.
But it wasn't isolated as a specific, measurable diagnostic entity until 1925.
Right. The sources mentioned two physicians, John Halley Bradbury and Charles Eggleston. They published this landmark case series of 3 patients, and they coined the term postural hypotension.
And the crucial distinction they made back then was separating this sustained pressure drop from just everyday fainting.
Because everyday fainting or, vasovagal syncope is what happens when someone locks their knees at a choir concert.
Yes, exactly. It is a transient, overactive reflex. The heart rate and blood pressure drop suddenly, the person falls down, gravity equalizes the blood flow, they wake up, and they are essentially totally fine.
But Bradbury and Eggleston's patients had a sustained mechanical failure. Their blood pressure fell dramatically upon standing, and it stayed dangerously low for as long as they remained upright.
Right. And eventually, the medical nomenclature evolved to orthostatic hypotension, just to be more precise about the actual act of standing upright and actively fighting gravity.
Which brings us to the modern definition. Fast forward to 1996, and then reaffirmed in 2011, the medical community decided they needed a strict standardized yardstick for this mechanical failure.
They needed a number.
Yeah, a consensus statement defined OH as a drop of at least 20 millimeters of mercury in systolic blood pressure, or at least 10 millimeters in diastolic pressure within 3 minutes of standing.
The famous 20-10 rule.
So what does this all mean? Let's apply some math to that, because having a rigid number in medicine always raises red flags for patient care, doesn't it?
It really does. It creates massive blind spots.
Right, because if you have a patient with a high resting systolic blood pressure of, say, 180, and they stand up and drop to 155, they have dropped 25 points.
So they easily meet the 20-drop rule for the official diagnosis.
But at 155, they have plenty of pressure to perfuse their brain. They probably feel completely fine.
They are clinically asymptomatic despite meeting the diagnostic criteria perfectly.
But then, take a frail 80-year-old patient whose resting systolic is only 100. If they stand and drop 15 points down to 85, they do not meet the bureaucratic 20-point definition.
No, they don't.
But at a systolic of 85, they do not have enough pressure to pump blood all the way up to their brain, and they might literally fall over.
Doesn't a fixed one-size-fits-all number completely ignore the physics of the patient's actual reality?
It does. And it creates this massive tension between clinical researchers and bedside doctors. Geriatricians and the physicians who are actually catching these falling patients, they argue heavily for symptom-based or function-based criteria.
Because they actually see the falls happening.
Exactly. They care if the patient is dizzy, if their vision is blurring, or if they are actively losing their balance. The functional perfusion of the brain matters infinitely more to them than some standardized threshold. They're treating the patient, not the math.
Exactly. But the researchers who are studying the underlying autonomic diseases, they desperately need that fixed 2010 number.
Because of the data.
Right. If a scientist is running a global, multi-center clinical trial on a new drug, they can't log patient felt a bit woozy as a data point.
Yeah, that's a number.
They need a reproducible, comparable threshold to measure efficacy. So both camps are totally justified for their specific purposes, which means in the real world, the definition is just always a bit contested.
But, I mean, this entire debate over whether the drop is 15 points or 20 points is completely useless if we are measuring it wrong in the first place.
And we are.
Looking at the data in the source material, it seems we are getting it wrong almost every single time in standard clinical settings.
The measurement trap is honestly one of the most frustrating blind spots in routine medical care. There is a very strict clinical protocol required to capture this fluid shift accurately.
Walk us through it.
Okay, so the patient must rest flat on their back supine for at least 5 minutes. This allows the cardiovascular system to reach a true gravity-neutral baseline.
Right.
Then they stand up. The clinician must measure their blood pressure at exactly 1 minute, and then again at 3 minutes.
And the 3-minute mark is where the entire system falls apart, isn't it?
Completely falls apart.
Because a nurse or a clinician is running behind in a busy clinic. They only have, 15 minutes allocated per patient?
If they're lucky.
Right, so they have the patient stand up, they slap the blood pressure cuff on immediately, take a single reading, see that it looks totally normal, and they just move on.
Yep. And because they skip the 3-minute check, they completely miss what is called delayed OH.
Delayed OH. This is a mechanical failure where the blood pressure doesn't actually crash until somewhere between 3 and 10 minutes of standing?
Yes. We could think of it like a failing water pump in a basement.
Oh, I like this analogy.
For the first minute or two, the pump works furiously and actually manages to keep the water level steady, so the immediate blood pressure reading looks fine.
But the pump is burning out.
Exactly. By minute 4, the motor just fails, the pressure bottoms out, and the basement floods.
So by missing that burnout phase in the clinic, they generate a false negative. The patient's chart says their orthostatic vitals are completely normal.
But in reality, if that same patient stands in their kitchen cooking dinner for 5 minutes, their internal pump fails, they lose brain perfusion, and they black out.
It's scary because we often treat a drop in blood pressure upon standing as one singular monolithic event. But the sources point out the underlying mechanisms create a whole family of drops.
A whole family, yeah. You have classic OH, which is the 2010 drop within the first 3 minutes. Then you have initial OH, which is this exaggerated, massive drop in the very first 15 seconds of standing, but the body immediately self-corrects.
And standard manual blood pressure cuffs cannot even catch initial OH because the mechanical inflation just takes too long, right?
Right. You need continuous beat-to-beat arterial monitoring to even witness it happening.
We also have the delayed OH we just discussed. And finally, there is postprandial hypotension.
Yes. This is a related but distinct mechanical drop that happens specifically after eating a meal.
Which ties directly back to that splanchnic balloon we discussed earlier.
Exactly.
The body redirects a massive volume of blood to the gut to aid in digestion. In older adults, especially, nursing home residents, that splanchnic pooling is so severe that if they stand up immediately after a heavy lunch, their already taxed system just cannot fight gravity.
And their pressure completely bottoms out. It is a huge contributor to afternoon falls that a standard morning clinic check completely misses.
And measuring this wrong has devastating consequences.
Yeah.
We're not just talking about feeling a little lightheaded here.
No, not at all.
For vulnerable populations, OH is a major, highly modifiable contributor to traumatic brain injuries, hip fractures, or just the permanent loss of independence.
The nursing home tragedy outlined in our sources is arguably the most common and, frankly, heartbreaking scenario we see.
Yeah, let's paint that picture. Imagine an elderly patient in a care facility. A doctor checks their blood pressure. While they are sitting in a chair, it reads high. They have seated hypertension.
Right.
Doing their job to prevent a heart attack or a stroke, the doctor prescribes multiple blood pressure medications to get that seated number down.
And those medications often work by vasodilating, which is chemically forcing the pipes open or acting as diuretics to reduce fluid volume.
So we are intentionally inducing the leaky pipe and low tank plumbing issues we talked about earlier.
Exactly. We are creating the problem.
So later that evening, the patient stands up to go to the bathroom. Because of the heavy load of vasodilating medications, their body is chemically blocked from constricting those vessels to fight gravity.
Their blood pressure crashes, they lose perfusion to the brain, they get dizzy, and they fall, often shattering a hip.
And the real tragedy is what gets written on the chart.
Yes.
It gets logged as a mechanical fall, or it is blamed on unsteadiness, generalized aging, or even dementia. The fall is completely misattributed.
The very treatment that was intended to reduce their cardiovascular risk became a direct, immediate fall risk hazard. If someone had just checked their standing vitals at that 3-minute mark, they would have seen the numbers crash and they could have adjusted the medications.
It's so preventable. Another massive real-world example of the wiring failing is diabetic neuropathy, isn't it?
Oh, absolutely.
We always hear about how long-standing diabetes damages the nerves in the extremities, causing people to lose sensation in their feet.
Right, peripheral neuropathy.
But the exact same degradation is happening to the microscopic nerve fibers that carry the baroreflex signals. The chronically high blood sugar literally degrades the myelin sheath and damages the wiring of the autonomic nervous system.
So a diabetic patient can have totally normal blood pressure sitting down, but the moment they stand, the electrical signal simply never reaches the brain.
And that structural nerve damage leads directly into some incredibly dangerous clinical misconceptions in the real world.
It really does.
The biggest one being the instinct to treat the fluid tank instead of the wiring. You see a patient whose blood pressure is crashing when they stand, the immediate instinct is to assume they are just dehydrated. The logic is, give them a glass of water, run an IV of saline.
Which is misconception number 4 in the sources. 4V fluids will not fix a broken baroreflex.
Right.
If the patient has Parkinson's or diabetic neuropathy, their fluid tank is completely full. Their fluid status is normal.
Overloading them with saline does absolutely nothing to fix the degraded nerve wiring.
And it can actually push them into heart failure by overflowing the tank.
Wow. Another misconception is the assumption that OH always causes fainting. The flawed logic dictates that if a patient isn't actively passing out, they don't have the condition.
And that is so dangerous. A huge proportion of patients with chronic neurogenic OH are entirely asymptomatic.
Really?
Yes. Over months and years, their brains simply adapt to operating on a lower perfusion pressure. They might feel a little tired or, experience vague cognitive fog, but they don't faint.
So if a doctor waits for the patient to explicitly complain of dizziness before checking their orthostatic vitals, they will just miss the diagnosis completely.
Exactly.
Here's where it gets really interesting. This leads to an incredible paradox in treating these neurogenic patients. Let's say you properly diagnose a patient with severe neurogenic OH. Their standing pressure is dangerously low, and you want to fix it.
Right. You want to keep them safe on their feet.
You give them a medication like midodrine. Midodrine acts as a chemical clamp on the blood vessels, forcing the pressure high enough to keep them safely conscious where they're standing up. But what happens when they go to sleep? The pill doesn't know they laid down.
It creates the ultimate medical tightrope. We call it supine hypertension.
Okay, explain that.
So the patient's regulatory system is broken and cannot adapt to positional changes, right? You chemically clamp their blood vessels shut during the day. When they go to bed at night and lie flat, gravity is no longer pulling the blood down to their legs. The fluid is evenly distributed again.
But their blood vessels are still chemically forced chemically forced shut and pumping hard because of the midodrine still in their system.
Exactly. The exact same patient who was at risk of fainting from low pressure during the day is now at severe risk of a hypertensive stroke while they sleep.
Oh my God.
Because their lying down blood pressure has just skyrocketed against those clamped vessels.
It is a terrifying balancing act. The sources mentioned that sometimes the only safe solution is having the patient literally sleep with the head of their bed elevated on physical blocks, just to keep a little bit of gravity in the equation at night to prevent a stroke.
It underscores the golden rule of autonomic medicine. You have to treat the patient's function, not just a numerical target.
Which brings us to the final and perhaps most profound revelation in our source material. We have spent this entire time looking at how orthostatic hypotension causes mechanical falls today, right in the present moment. But in some patients, this vital sign is actually a warning siren for what is going to happen to the brain years from now.
This is where the science shifts from reactive mechanics to, honestly, visionary neurology.
Let's talk about Scheidegger syndrome, or what modern medicine now calls multiple system atrophy, or MSA.
Yeah.
This was first described back in 1960. It's a condition where severe OH is combined with Parkinson-like motor symptoms.
Yes. And for a long time, doctors just treated the blood pressure drop and the motor tremors as like separate issues that just happened to show up in the same patient.
But the clinical consensus eventually shifted as the pathology became clearer.
Right. Exactly. They realized MSA is a specific type of disease called a synucleinopathy.
Okay.
It is caused by misfolded alpha-synuclein proteins clumping together in the nervous system. These abnormal protein deposits physically gum up and suffocate the nerve cells.
And that is the exact same underlying mechanism as Parkinson's disease.
Yes. If we connect this to the bigger picture, delayed or neurogenic OH isn't just a quirky vital sign abnormality, it is often a prodromal clue.
Meaning pre-diagnostic.
Right. It acts as a pre-diagnostic signal pointing directly to a neurodegenerative disease long before the classic symptoms ever appear.
Because the autonomic wiring, the subconscious nerves controlling your blood pressure, your digestion, your temperature, it's all incredibly delicate, right?
Very delicate. Those autonomic nerves often succumb to the misfolded protein deposits years before the motor cortex does.
Yeah.
So years before a hand tremor or a shuffling walk ever becomes visible, the baroflex starts to fail.
So a simple, properly conducted vital sign check in a general medicine clinic might just be the earliest visible thread connecting a patient to a major neurodegenerative diagnosis a decade down the road.
It is quite literally a neurological crystal ball hiding inside a $50 blood pressure cuff.
That is just wild.
It really underscores why understanding the mechanics behind this basic low-tech screening tool is so incredibly powerful.
As we wrap up this deep dive, let's take a step back and look at the mechanical journey we just mapped out. We started with the sheer physics of it. The massive volume of fluid pulling into the splash-check balloon every time you stand, and the nucleus tractus solitarius frantically signaling the vessels to clamp shut.
The amazing baroflex arc.
Yeah. We navigated the 2010 rule and why treating a fixed number ignores the actual perfusion of the patient's brain. We broke down the plumbing versus wiring distinction, separating the leaky pipes from the degraded nerves.
Right.
We covered the absolute necessity of that 3-minute check to catch the failing pump of delayed drops. And we explored the terrifying paradox of supine hypertension, where chemically fixing a fall risk can inadvertently create a stroke risk at night.
I want to speak directly to you listening right now. If you, an aging parent, or any family member ever complains of feeling dizzy or heavy when standing up, or if they're taking multiple blood pressure medications, you now hold a very specific, actionable piece of knowledge, to advocate for the full 3-minute orthostatic vital signs protocol. Do not let a rushed clinician check it immediately and move on. Insist on the 3-minute wait to ensure the internal pump isn't burning out.
Yeah.
It is one of the highest yield, lowest cost interventions in all of medicine. It takes exactly 3 minutes, and it can prevent a catastrophic, life-altering fall.
It is so empowering to realize how much control we can have over such a massive invisible risk.
Mm.
But before we go, I want to leave you with one final lingering thought to mull over. We have spent this entire time deconstructing what happens when the Bareflex fails to respond to gravity.
Right. The pressure
The
drops.
blood pressure drops, the brain loses oxygen, and the system crashes. But what happens when the reflex doesn't fail, but instead goes into an absolute panicked overdrive?
Oh, this is fascinating.
There is a condition called POTS, postural orthostatic tachycardia syndrome. It is incredibly common in younger people, particularly women. When they stand up, their blood pressure doesn't drop at all,
The pressure stays perfectly stable.
but their heart rate absolutely skyrockets. It races out of control, maintaining an excessive, exhausting compensatory response just to keep them upright.
It is a fascinating mirror image of everything we just explored today.
And a perfect reminder of how incredibly delicate the balance of our autonomic nervous system really is. Until next time, the next time you push yourself out of a chair and walk across the room, take a second to appreciate the silent, split-second medical miracle happening inside your chest and your neck, actively fighting off gravity just to keep you on your feet.